Hey everybody, this is Kevin with Nursing KAMP.com, and this is my 7th video of Mastering NCLEX Nursing School and how to look at the content when you're studying for NCLEX and testing. I look at 7 different things that are tools to use while you're in class and how to look at the lectures. In this one, I'm going to talk about what's behind me right here, which is Conceptual Camp, which is a critical analysis of the content and your understanding of it. So let's get into this video. So this is video number 7 of Mastering Nursing School, and the course that covers all the 7 areas of it. And today we're going to talk about Conceptual Camp. And what we talked about previously, we talked about the 4 squares method and how you isolate content in lectures, how to build a burn list and compare that burn list with the content, the meds, the diets, isolation procedures, labs, and how to conceptually look at this content, pulling it all together, and how to compare your burn list with other students to see whether you're on the right topic and whether or not you are getting all the content that you need to know for your test and the NCLEX. And then I went into further ways of looking at the information, and we said that sleeps is a method that is used to look at this information and how it starts. And today we're going to talk about DVT because it's pretty familiar. Actually, let's talk about because it's pretty familiar in what we're talking about when we're talking about the complications of it. Then we talked about medications and AWALs of how it works, and I actually forgot in this where there's an H there. I spelled it wrong. That's hold, and when do you hold it? ALEEPs, where is another thing that you look at for looking for procedures. Like we did a CT scan, or not a CT scan, a spinal tap, and then we talked about NCLEX questions and how to study questions and how to look at things. And this is from this NCLEX study plan that is available on nursingkamp.com, which kind of goes over those 4 square areas. It shows you the sleeps, the ALEEPs, and the AWALs. This will be available on this web page, so you can just download it when you are looking at the content what we're talking about. So the next thing we're going to talk about is the conceptual camp, and this is a conceptual model of this content. And like I said before, we're going to look at DVT. And when we're looking at this, is like, do I know what's going on with this content in a full way, that I could really look at it and basically understand what is happening here? So let's go into it. So when we're looking at this, so the first section over here is presentation. So if you're looking at the presentation of the person, right, this person right here is walking around. Could a person who's walking around get a DVT? Yeah, they could, right? I mean, they could be stationary for a period of time and suddenly start to get this cramp, what's going on, and this and the other thing. And they might actually be sitting in a doctor's office figuring out, why is this happening? You know, why do I have this swelling of the leg and different things? You know, why is it warm and stuff, ipsilateral? You know, could they go to call it 911? Not most likely, but they could. But most likely that they present to urgent care or something's going wrong with them. They could go to the ER, right? They will probably drive to the ER, have somebody bring them there to present to the emergency department. But it does mean that they're not going to wait around to the doctor's office generally. You know, I mean, they probably go to the emergency department. Could they be sitting in a bed? Yeah, they could be sitting in a bed. You know, that's true too. So they could, so we monitor post-op patients. That's why we get them up and moving and all those types of things. Male and female, is any differentiation? A little bit more with females because of birth control pills, estrogen, different things like that. Males, not more so females, but males too can have it. Any age relation, this can happen to anybody. So there is no age. So this right here is your age block. You try to figure out, you know, what's most acute. And we're looking at ages on this. So I'm saying that this main concept is a DVT. We start to think critically about this. And this is conversation. You can sit here and say to your people you're studying with, this is like, you know, what do you think about this, and the other thing? It's whether or not you truly understand what a DVT is and the presentation of it, which means the next thing. If I ask 10 students right now, what are the top 3 symptomology that they would have? And the top 3 symptomology would be ipsilateral, right? So it's not bilateral, which means that calf pain, right? That's swelling on one side. That's very distinctive of a DVT, right? Warmth, that's another very distinctive thing, and erythema or redness or pain, right? So we're looking at symptoms 3. We want to kind of say, well, what's most likely? And when we're looking at 4 squares and we're looking at questions, when DVT shows up, these symptoms tend to be the most likely presentation. And that's why we look at it this way. So we basically look at the sheet in a way that we try to force ourselves to pick the top 3 most likely things of it. You know, so when you're looking at somebody with, you know, right-sided heart failure, for example, you have bilateral edema, right? You have hepatosmegaly, the swelling of this. And you also get some anorexia where they don't really want to eat, you know, and stuff like that. So very specific of right-sided. And left-sided, you have lungs, crackles, shortness of breath, and so on. So when you're sitting together, you say, what's your symptoms 3 of this condition? Because that's the most likely presentation of a question of symptomology of it. You have to be familiar with symptomology, and you also have to be familiar with precipitating. What would cause a person with a DVT was precipitating? Well, it comes back to Virchow's triad. And Virchow's triad states that 3 things that would cause a clot: stasis, sitting around. That's why post-op patients get up and go. Right? Long bus rides, you know, we tell them to get up, move around, you know, don't sit in the things, you know. And trauma, you know, like a surgery. What's the main complication? We talked about this previously, PE. That's the main complication of this. This is that a DVT, thromboembolism, right? Thrombus means, you know, stationary. Pulmonary embolus means embolism, movement of it, right? So now it's moved all the way through the body, up from the calf, all the way up to the lungs. And that's a major, major problem. The acute 3. What's the acute 3 of a DVT? What does that mean? Well, the acute 3 is, what would I call the doctor for middle of the night if the patient had a DVT? Well, if they're showing signs and symptoms of a PE, or, you know, they start having shortness of breath, PE, bleeding, PE, complications of medications they're on. And those are the 3 things. Now, this is a discussion that you have amongst your study group, and when you're trying to figure out, or you're working with yourself to try to really isolate it. How else do you see these acute 3s? Remember the 4 squares? When you're doing questions, the more questions that you do, the more, you can only flip a DVT so many ways. So you can only test on so many things. After a while, it's the same stuff. So the NCLEX is saying, does everybody in the room know about a DVT? You know, and what's most likely to know about this DVT? And that's what the NCLEX will tend to test on. It's always based on safety too. So bleeding shows up, right? Also complication that it becomes a PE. All right, so let's move over here to what do I anticipate? You know, are they going to be on the monitor? Well, the pulse ox is important. Cardiac, not really, not most likely. They could be. They don't need to be. It's not like a cardiac arrest or a myocardial infarction. They need to be on a monitor, right? So somebody's peeing, puking, and pooping, you know, needs to be on a monitor because hypokalemia, you know. But this patient's a DVT, so they wouldn't be on a monitor, right? So what about blood pressure? Any changes in blood pressure would be monitoring the vital signs? Not really. It's not the most likely. It's not something, yeah, you do it, but Q shift, but not really like, oh, every hour I need to check the blood pressure. No, not necessarily. It's not really hemodynamic. It's an occlusion. All right, what about labs? Yeah, we talked about this before, D-dimer. D-dimer is very specific of DVT. Positioning, you know, would they be high followers? Would it be supine? Would it be prone? You know, do I know? You know, if you don't know, then you go study that content. Well, we know that DVTs, they're going to be bed rest, right? Because they have a clot that's down there. So we don't want, if we know that the clot's there, we don't get them up and moving, because that could mobilize that clot and it could go into the lungs, and we don't want that to happen. So there'll be bed rest. All right, so what about diagnostics? Chest x-ray, yeah, they could have that. Most likely a CT scan, a spiral CT is the most likely. But they could get an ultrasound, right, of the legs to look for the DVT. Now, ultrasound is a procedure, right? So procedures get the A leaps. So then you go through it. A venous ultrasound, acute or chronic. It's chronic, you know. I mean, you don't call the doctor at 2 o'clock to get an ultrasound, you know. What's it looking for? DVT, right? Can they eat before? Sure, why not? Assessment before? I don't know, nothing really. Assessment during? We don't test on during. How about afterwards? Nothing really invasive about it. Any prescriptions related to it? Not really. Any problems with an ultrasound of the DVT? No. And what stands out? What's the 3 things? Nothing really. You know, it's just an ultrasound. It's a diagnostic. It's a diagnostic test. Okay, how about medications with the DVT? Yeah, they could be on a heparin drip, which means this over here. And we'll be monitoring them. We're monitoring their coags and their platelets, and then their H and H, you know, because they're on a heparin drip. What about PO meds? Well, not necessarily, unless it's a chronic DVT issue or PEs. They have chronic PEs. That's not most likely. Okay, so then the labs. Anything here? Potassium, sodium? No. Chloride, CO2? Maybe if, you know, a PE is developing, but that's not most likely. B1 and creatinine? No. Glucose? No. White count? Yeah, actually, white count might be a little inflammation. Right? So, which means that a DVT is inflammation, right? Occlusion, which means you might have a slight bump in that white count. Not like 18,000, but a white count is, you know, 4 to 10,000. Right? See, there's 4 spaces in the CBC. So 4, and it looks like an X, so 4 to 10,000. H and H, in case they're on a heparin drip, platelets, right? So also bleeding. Calcium mag phos, no. Liver, not necessarily. Pancreas, no. All right, how about temperature? Yeah, they might be mildly, you know, inflamed, but not really. Pulses, yeah, they could have, but you know, ipsilateral pulse problems because of DVT, right? So, you know, popliteal, where they're at. Respirations, they could start to become tachypnic, which means they're having a PE. Blood pressure, not necessarily. Mean arterial pressure, no. Pulse ox, yes. So we have pulse ox and we have respiratory increasing. Fluid status, not most likely. Pulses, we said ipsilateral. Any cardiac enzymes? No. Any ABGs? Well, if I'm doing an ABG, that's an evaluation of ventilation versus quality. If I have a PE, it's right now. I mean, I'm not going to be waiting for an ABG to see whether or not this person is breathing or not. You know what I mean? I know it's a PE because they're a DVT. Now they're having shortness of breath and they're spitting up blood, and you know they have an S3 heart sound. You know, I mean, that means it's a PE. I don't need to go get an ABG for that. I don't need that. Cementation, yes. They start to get a little bit irritable, panic, heart, tachycardic, lungs. It's all lungs because of P's the risk. Kidneys, not necessarily. Surgery, could be post-surgical problems with it. Well, can they just walk out of the hospital from this? Yes, they can. Can they just be discharged? Yes. Where could they be? Will they be on the med-surg, tele, or ICU? Well, it depends on the stage of the DVT. They could get it on a med-surg floor. It can be on tele floor. It can be on any of these floors. But where they're going to be admitted, I mean, it depends on if they have a heparin drip or not. Okay, so the nursing 7. What's the nursing 7? The nursing 7 is, if I was to look at this whole entire sheet, I asterisk 7 things. And that's the most likely to be tested on. So I think, okay, well, this is 1. The PE is 1, knowing that DVT goes for that. Symptomology is another. Heparin is another. Labs is another. So that's 1, 2, 3, 4. You know, shortness of breath is another. Precipitating is another. And then I go from there. So how do I define this nursing 7? That's when you study together. You know, what's your nursing seminar? DVT. What do you have? I get this. I have this. I have this. Why'd you pick that? You know, and then you figure it out. So that's this conceptual map. This is how you look at content when you have the content, right? So, you know, instead of DVT, this could be an MI, or it could be a PE. It could be right-sided heart failure. It could be, and so on. It could be Graves' disease. I mean, it could be all these different things. It's just to look at it. What's this guy for? Is to recognize the pathophysiology. You have your mentation up here. You have your nasal. You have your thyroid. You have your carotids here. This space right here is vasoconstriction. This is volume. You know, your lungs. The lungs get broken down over here. Liver. And then it's basically to visualize what you're seeing right there. This is a conceptual model. This is looking visual at your content in a way that really expands your content and pulls everything together. Well, that concludes this lecture on how to study for nursing school and to understand whether or not you understand the content at a level that is most likely to be tested on the NCLEX and for nursing school. Work together, guys, when you're working with one another, when you're studying together. Utilize these methods in order to isolate what each of you know so that everybody knows the same thing. Not what's the nuts to know that nobody knows, only that person knows. And you don't need to know all that. You just need to know what everybody in the room knows. And that's all it is. That's what studying is about. It's not going far down the rabbit hole. Listen, when you're in nursing practice, you can go down that rabbit hole. But right now, you just need to isolate, figure out what you need to know, study what you need to know, and stay on the course. My name is Kevin, and this is Nursing Camp. We'll see you next time, and nurse on.